Hello everyone, and welcome to the Understanding the Core Components of Return to Work Programs for Individuals with Musculoskeletal Disorders webinar. We're glad to have you here today. This webinar is part of our Return to Work Stay at Work series, and we're glad you're here. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Direct Access Program through the BC Government. As I mentioned, my name is Tanya, and I'll be moderating the session and handling the Q&A session today. And our presenter is Dr. Katia Costa-Black. Dr. Costa-Black is currently a senior lecturer in the School of Health Systems and Public Health at the University of Pretoria, South Africa. Prior to assuming this role, she was a postdoctoral fellow at the Dalai Lama School of Public Health at the University of Toronto, where she received a CIHR Knowledge Synthesis Grant to investigate the core components of return-to-work intervention and implementation. A physiotherapist and ergonomist by training, Katia's scientific interests and publications span the areas of program implementation, program evaluation, and evidence synthesis related to the field of work disability prevention. And now I will be handing it over to you. Go ahead, Katia.
Thanks, Tanya, and all of you for joining us in this webinar. This presentation today, I will share with you some of the results of a knowledge synthesis project that I conduct during my postdoctoral work at the Dalai Lama School of Public Health at the University of Toronto. I also will be describing here today some of the challenges for researchers to extract effective intervention components from the literature and the methods that have been used and suggested so far. I would like to start by saying that this project was funded by the CIHR Knowledge Synthesis Grant, and Dr. Patrick Loisel was the PI in this project. And we had the pleasure to collaborate with a multidisciplinary team of researchers from Canada, France, and the Netherlands. What was interesting about this knowledge synthesis project is that since the very beginning, even in the developing of the proposal, we, the researchers, collaborate with several decision makers from well-known Canadian entities. This interaction with decision makers was a requirement of the type of CIHR grant that we obtained, and it clearly presented great translational gains. There has been great scientific consensus about the fact that a successful return-to-work program for people with musculoskeletal disorder should take into consideration the biopsychosocial dimensions of work disability. And many return-to-work programs available today take this perspective into account, and they elaborate a rehabilitation intervention package and program that pretty much follow the principle of reducing all the obstacles to return to work at these three levels, the biopsychosocial. The corresponding intervention package must include all the necessary components for that, such as a prompt access to clinical treatment, modify work when necessary, change in behavior and beliefs, involve the employer in the return to work process, provide social support, and make sure that all stakeholders communicate and cooperate with the return to work plan. By following these evidence-based principles, many intervention programs or packages have been designed and tested by randomized controlled trials. A well-known example is the Sherbrooke model that was developed and tested in Quebec for subacute back pain in the mid-90s. This multifaceted return-to-work program is a pioneer in testing a combination of clinical and occupational intervention, and its main effective components are mainly the address disability determinants, not the disease, follow interdisciplinary and interorganizational approach, place the rehabilitation process in the workplace. As you can see in the graphic, the Sherbrooke model and program show a faster return to work to regular job in comparison with all other treatment programs available at that time. When a similar intervention package was carefully adapted to the Dutch context, the results were also very effective in reducing the number of days on sick leave for back pain patients. And again, a few years later, another randomized controlled trial with similar components as the Shabrook model, but this time for chronic back pain patients, show effective results in reducing the sick leave days and keeping the injured workers at work. These examples point out that knowledge of evidence-based interventions has been accumulated. Now the question really becomes how to make the best use of it. As a knowledge synthesis project, we were interested in discussing the issue of knowledge utilization with the decision makers in our project. In our initial consultation with them, the issue of local applicability and transferability of successful intervention was strongly emphasized. The main question of interest of all of them, to all of them, was which intervention components are essential to be delivered across return to work programs implemented in different settings that can maintain the same level of program effectiveness as the original. And putting this question in a format of a research question, our question was, which are the core components of return to work interventions for musculoskeletal disorders, and how are these components described in the published literature? And this knowledge synthesis project was developed using the theoretical basis of the implementation framework developed by Dan Schosser and colleagues in 2009. If you look into an intervention, can be adapted, we consider with great distinction what means the core components that should remain intact and the characteristics of that intervention, which on the other hand can be changed according to each local setting. In this framework, the characteristic of the intervention that might change when implementing different settings, it's called the adaptable periphery. And here we consider also the process, the evolving process of the implementation in the particular setting, the individuals that are involved with the implementation, and the outer setting that also includes all the external variables in relation to social political scenes. And then it is helpful to understand intervention components if we compare them as the active principles in a medication. And imagining the bottle, the package, and even the color of the capsules could be different in each place, but the main active principles that make the medication works must be kept intact. In order to avoid as much as possible misunderstanding about what really is the essential intervention components, it is necessary to map the different literature in a coherent and interpretative model using well-defined principles of implementation research already in place. The problem is that in the published literature we often encounter with complex and multifaceted interventions in which we know very little about the details of what are the essential elements of the intervention that make the program effective. Many intervention components might be tested together, and it becomes difficult to understand which ones are essential to be kept with fidelity. There are several methods that are available in the literature in regards to how to extract intervention core components. And the leaders in this field are HIV/AIDS prevention and substance abuse prevention. And the references that are suggested by authors in these fields refer to methods such as within-person and within-organization research designs, focus on program practice, and that information combined with getting information from published literature. And also it's suggested that it's the best way would be to consider a meta-analysis study to identify those interventions that can be supported by a series of RCTs, but in this case they have to be theoretically and methodologically consistent across different studies, which is not a reality for most of return to work interventions. And if you consider the taxonomy of components, we are also, there are references that suggest a non-traditional literature review that could look into other types of study designs besides a randomized trial. Another way of extracting intervention core components is by developing with the program developers the program theory or logic models. And these are standard procedures to follow to arrive to the components. And it's very challenging to find the right method to extract the core components. But up until now, because of the complexity of return-to-work interventions and the diversity of study settings and designs to evaluate this intervention, it has been difficult to identify and to replicate the components. We took this challenge of extracting core components by choosing a systematic review process that could be comprehensive and flexible enough in terms of the analysis and interpretation of various types of studies and various research traditions. It also should allow for analysis of the literature using high-quality appraising techniques and possibly with the involvement of decision makers in the review process. There was also a need to seek a method that used a narrative analysis of seminal papers and important papers in the field from well-known authors that could give us more detailed information about the black box of components, of return-to-work intervention components, and also that could give us information on the transferability of findings moving beyond RCTs. And we chose a meta-narrative review, which is a method developed by a group that works with Dr. Tricia Greenhalgh. And the first reference to this method is described in this slide, which is from 2004. And this method is particularly interesting approach to looking to a more historical and philosophical perspective in a pragmatic way, but also keeping the rigorous and quality appraisal criteria that are required for a systematic review. And in the very beginning of our analysis, we had to make decisions on how we would retain the core components. And the identification of these components and decisions that we made as a research team and together with some of the decision makers was really trying to track what kind of information that were changing across the studies. And also we're looking into a very important reference in the field, which is the randomized trial that was done in 1997 with the Shabrook model. And from that, we looking into comparing how the intervention was implemented in different settings and see what components were replicating across different settings. The other way also we are looking to identify by looking and searching for any explanatory information on the theory behind the intervention if the authors had published any types of theory of the intervention, and that was very relevant to retain the core components. The second part, after we identify the components, was we carefully trying to synthesize this information in a way that we considering different research traditions, and we trying to combine the knowledge and expertise of our research team that had very different areas of expertise to make an interpretation that was transdisciplinary. And we also look into conflicting findings and resolving them in the best way by consensus between the group, and we created a narrative log to allow us to make analysis of what we're cataloging as component. And there's a description of the phases of the method, the meta-narrative technique, in these references listed here. And it's important to emphasize that the meta-narrative technique is very similar to any systematic review process. As you can see, the phases are very, very similar. But what stands out to be from this method is that you can engage decision makers in any phase of the review, and there's also a required overlap between the phases. And we move between the phases according to this overlap. So during the search phase, for instance, you can start mapping some information, and you might need to go back and do more search while you're mapping that information, which is very helpful for this process. There's also a very inclusive, exploratory approach to looking to the interpretation of the findings of the studies, and then with the recommendations we include decision makers also in that phase. And in the search methods, we begin with the informal search and the search phase, and in the very beginning we contact the decision makers to get them the references of the most relevant papers on return to work programs and intervention that they've been using in their practice. We also consult peer experts and researchers from within and outside our team. And we did manual searching of all the relevant journals in the field, and we searched the gray literature as well to identify the main studies that had been recognized by these organizations. We also, in the formal process, we were carefully trying to be as transdisciplinary as we could, including a lot of information coming from diverse databases that could look into different research traditions, not only the medical science literature, but going beyond and looking to a Costa-Black, which is an engineering database. And we use reference manage to look into overlapping of papers. We limit to English studies, and we look into all the studies that were in return to work intervention for musculoskeletal disorder using a combination of the concepts that are listed in there. And we are searching for 1990 to 2010. And when the map and appraisal phase, which I mentioned it before, that we involve the decision makers in the very beginning of it. In the appraisal phase, it was difficult to engage with them, and we really work a lot more with the researchers at that phase. And we had two reviewers to do the selection and quality appraising of all the papers that were selected. We developed a data extraction form, and this was based on a version that was originally published by Greenhall et al. 2005. The form is it's much longer than what you see in the screen, but for now, just to give you a bit of a sense of our first level of screening, where we are looking to the papers that had most relevance in the field or worth, and asking the question, is the paper about interventions for preventing work disability, maintaining workability, reducing sickness absence, or increasing the chance for return to work, and they were more specific into how they are recognized by others as well. And the second level in screening, we're looking more in terms of the type of studies and looking to the relevance in the field. And in order to determine, we ask the question of relevance: does the paper specifically test or report the effectiveness or cost effectiveness of a return to work intervention or one of its components for individuals with musculoskeletal disorder? And in blue, we classify all the papers that were essential to include according to the type of studies, the study design. And some of the studies that were very relevant in the field, but they were not effectiveness study, we classify them in a secondary analysis. And in the results session, we identify 2,446 studies and research reports in return to work for musculoskeletal disorder. And after our first level screening, by looking only at titles and abstracts, we retrieve 532. And it's important to note that the original studies, which are 76 total of studies, from these 76, Only 27 were high-quality studies, testing intervention effectiveness and effectiveness studies with cost evaluations, like high-quality trials, cost-effectiveness cohorts, and pre- and post-test study. From this study, a list of 15 intervention components were retained and further evaluated in terms of the supporting body of evidence coming from other sources of evidence. These other sources were the remaining original studies, and these included economic evaluation studies alone, not together with RCTs, and complementary studies such as qualitative research, conceptual papers, process evaluation research, and surveys describing or reporting a single intervention component. Highly relevant scientific reviews and reports were also analyzed in terms of the support they provide to the essential components. In order to enhance our understanding of the intervention components and their potential benefits or their links to different systems, a narrative log containing the description of each component was conducted. We create, excuse me. We create this log to give an idea of, I'll show you now an overview of the log. You don't need to read, but basically these descriptions would help us with other reviews to identify the coherence between the components that we analyze in the evidence, the strength of evidence. And we classify the information in three groups because the components were either referring to components directed at workers or the components were directed. And our grading of evidence that was used in this project is a very similar methodology that has been proposed by the National Institute for Health and Clinical Excellence. And we classified A, B, C, and A for strong base evidence, B moderate, and C limited research-based evidence. And there is a whole grading system to look into the amount of studies, the type of studies that are classifying this grading. And our first, in this first table, I present to you the results for the interface with the workers, and the main components are cognitive behavior approach, education to promote self-care and pain management, education and advice about activity and work, exercise program, protocol-based clinical management, work disability or ability assessment. And you can see the supporting evidence has these columns that that shows the studies that had support the different types of studies, and you have the effectiveness study as really the main supporting evidence for cognitive behavior approach and education advice about activity and work. And some of the components lack enough of to grade it as level A, but you see all of these studies, all of these components have supporting evidence either from effectiveness studies, from economic studies, and complementary study, as I mentioned before. It's here considered the qualitative research and the important essays in the field. And there were very few reports and reviews, and they were also considered for the analysis of the supporting evidence. And in the second group, we look into all the components are with the interface with the workplace. And a lot of studies, as you can see, we have studies that have evidence on strong evidence on ergonomics workplace assessment by itself, and the description of it is published in a chapter of the Handbook of Work Disability Prevention that I wrote. And within this description, sometimes the authors refer to the assessment as being in itself therapeutic for the return to work. And there are some of these components that's been tested as a single component, and others has been only tested as multiple components. You can see some of them has a asterisks on next to the name, and which means that they've been tested as a single component. And the other ones that doesn't have that, that means they didn't, there's not a study that look into it as a single component. And in the third group, we have the components with interface with stakeholders, and calling attention that one of the main strong components, strong evidence, was the communication between stakeholders, and also was highlighted by these, looking at the evidence, quite relevant. And then it's also important to highlight that by looking to these studies, we also identify a few components that were mentioned in really a large number of complementary studies, which mean mainly qualitative studies, but they're not yet being tested in high-quality effectiveness studies, and in this case, these components are not listed on the tables that you just saw. But the example of two of them is early and meaningful return to work and proactive disability management, which employee-based approach to that. And these are important components. We are suggesting that this could be important and should be tested in the future, and this shows a research gap on this type of components. And certainly it will be not feasible to implement a program containing all 15 components that you saw on those tables, but it's important to highlight that components with limited evidence today might present strong evidence tomorrow and vice versa. And when we talk about extracting core components, it's an ongoing information that has to be fitting in on the current research that's being done. So when we analyze this information, we have to take in cautions on the different levels of evidence that is being analyzed at that point and compared to the present. And naturally, the components with grade A and B should be the ones desirable to maintain in a return to work program. And the reviews and effectiveness studies continue to be considering the field a high hierarchy of levels of evidence, but one must consider that all components that have good supporting evidence with very large amount of study supporting from different types of study, economic evaluation, and also from qualitative research. This also makes an argument for using any of these 15 components listed on the table. And there is also, we have to consider that the limited knowledge exists today on isolating the effect of a single component, which make very difficult to justify just one component. As you can see on the table, there were very few components that have been tested as isolated single component and more as a package. And this difficulty is really clear when you're looking across different types of programs, and we question the fact that the effect might be due to the combination of components rather than a single component in isolation. But we also know from some very high quality reviews, as an example, as the review listed there, of effectiveness of workplace interventions, where it looks to 9 randomized control trials and identify that for the same back pain population, interventions involving stakeholders working together without any exercise component appear to be more consistently effective at helping people to return to work than an intervention involving only exercise. And we only now begin to really obtain the knowledge to isolate these effects and understand a single component, but we still have a long way to determine which one should be the priority for successful implementation. In conclusion, this evidence-based synthesis really shows to us that researchers should not make the decision alone on deciding which components should be implemented. And it's very important that we understand how to accomplish this job of extracting the information from the literature. And there are these methods that I mentioned before. They are new and they're being tested just recently, and there are a lot of more research needed to be able to really pinpoint which is really the best method to really determine. It's important also to highlight that the results bring high quality information to both researchers and decision making on what to implement, but it's more in terms of a dialogue with the decision makers, and this is a good way with the description of the components being in a narrative log. It helps this discussion with decision makers, and this kind of collaboration should be encouraged, and exchange of ideas with decision makers really help to really determine the relevance of these components in terms of the use in practice. And the description of the components and the current body of evidence supporting each component should be seen just as a communication tools, as I mentioned, and the clear description also allow for evaluations of the functions of these procedures in the future, which is very important for program evaluation. And the evolving nature of the evidence and the current research gaps on components suggest that more research should be carried out in the future, especially within person and within organization research designs that offer an effective way to experimentally determine the function of individual components of evidence-based practice. And I would like to thank you all for listening, and I'll take questions now. Tanya? Tanya?
Yes, wonderful. Let me see if we have any questions yet. I don't see any questions just yet. Attendees, if you want to, feel free to type in any questions you might have about the presentation. That would be great. So far, I'm still waiting. Just out of curiosity, while we're waiting for any questions from the audience, do you have any people or organizations that you have worked with that have given you feedback on this in a practical sense as far as the application of your research?
Yes, I actually has been quite an interesting journey for me. I've been working with program implementation in 3 different programs in Brazil, and one in particular has been really looking into this type of research to make decisions on what they're going to go and evaluate when it comes to designing the program, but now at the point where the information on the evidence, it helps them to see what could be part of the package that they are designing. And then from that point on, they are also carefully looking to evidence on components that's been tested and with good effectiveness, and looking into which ones could be adapted to the local settings that they are designing now.
Very good. Let's see. Somebody's asking, they were hoping to receive a list that included the core components for return to work after muscular injury. I'm wondering what those core components are, like a full listing of them, if that's available.
Yes, it's a full listing, and it's been most of this information that I presented today is being published in the chapter on the book, the Handbook of Work Disability Prevention and Management by Dr. Patrick Loisel and Hannah Nima. And this chapter it has the information on description of each component, and it does have the table with all the supporting evidence for each of these components.
And when is that going to be published, do you know?
It was published last year.
Published last year. And could I get you to send me the information about that book by email so I can post it for people to reference?
Sure, I will.
That would be wonderful. And let's see, someone asks, could these core principles be generalized to other disorders and return to work, or is there something that makes the core components musculoskeletal specific?
Yes, this is a very good question, and in fact the chapter that I mentioned, I made analysis of a review that was done in Canada by Dr. France, and this review was about mental disorders, and the comparison that we made in terms of the musculoskeletal disorders and mental disorders were very, very similar components, and you can even call principles. They are. I think the information that we have now in terms of using this nomenclature for components, it's coming from the implementation research field, which is quite new, and people are trying to really more and more understanding what these components really means. And most of the time when referring to principles of intervention, we are really looking into the theory behind the intervention and the explanation that is behind that intervention. When it talks about components, we are more accurate in terms of the effectiveness that it justifies the logic of that intervention that we are more interested in describing and understand better. And I think that it's valid to say that a lot of the information that we're seeing, even though the analysis comes from evidence from studies on musculoskeletal disorder, there are a lot of similarities on programs package and for other disorders that it's not musculoskeletal disorders that come in place.
Very good. And then there was someone asking if you could speak further about barriers that may exist to trying to promote return-to-work programs.
Barriers to try to promote return-to-work programs?
Yes.
You mean removing obstacles to return to work? I don't really understand the question, sorry.
I think they might be asking, like when you're trying to promote return-to-work programs to the people who would be implementing them, what barriers often exist. Trying to essentially maybe convince people as to why it's important or why it works.
Yeah, I mean, I've been facing barriers on implementation of return-to-work program and understanding programs in different countries and environment. I work in South Africa, and I had experience of understanding, and the barrier there has been more related to policy issues. And on the practical level, the barrier is training clinicians to understand better how to address these disability determinants. And these are particular for that setting in South Africa, and there is a program which I'm following, and they are close to propose a good evaluation study, which it will be the first in South Africa really investigating for musculoskeletal disorders, but they struggle a lot on training clinicians and putting together this program that could be close to evidence-based practice in other countries. And in Brazil, my experience has also been the barriers there are also related to behavior and acceptance of how to deal with the disability and avoiding looking too much into the disease and the pain and looking into more the determinants of what make people away from work. And there's a strong evidence on the work factors and the work determinants and workplace support system. And in Brazil, the corporate culture really is being a big barrier to promote this kind of program because of the corporate culture and business oriented towards production and really not really in tune in terms of health and safety in the workplace has been a big barrier. But there are good examples there, and it's coming from public health and new public health initiatives that are really developing ideas what combine rehabilitation, return to work, and active workplace surveillance, which are very innovative, I think, and they would be they already passed through a lot of challenge throughout the years, but they're very close to achieve something more at the national level. And this particular program that I'm thinking about in Brazil, it's a pilot study, and they have been really on pioneers on bringing stakeholders together and collaborating with a number of people that are being really able to articulate well of what the benefits are for early return to work and supported system in the workplace.
All right, and then there's someone asking, when referring to disability determinants, is there a list of common ones as well? And is there a reference to learn more about these?
Yes, I would love to share the reference. I can get by email the person who wants to know about this. I would be happy to share. There's a lot of information there, but in the handbook in itself that I mentioned, there are one chapter, I forgot the author, but that is particular for determinants on an individual level and a workplace level, and a stakeholders level as well, so you can look into the variety of types of obstacles to return to work to do.
Great. And then someone else asked, are there plans to develop new programs based on this research and continue research into early and meaningful return to work and proactive disability management?
The two components that was not being, it was mentioned by many authors and was not really tested yet. I believe that it depends on us researchers to make this as a part of the agenda. It's, to my knowledge, I don't know many studies. I think there are a few studies, not on musculoskeletal so far. There's one study that I know in the UK that is looking into this meaningful return to work for mental health problems, and I think there are publications already. I can look it up and send it to the person who's asking about that, but I think it should be more in this particular issue of meaningful return to work and proactive disability management should be in the agenda for in the future for other programs that are being developing now.
Very good. Thank you very much, Katia, for your presentation. I think it was very, very informative.
Thank you very much, Tanya, and I hope that we collaborate in the future.
I hope so as well.